We'll get going. Welcome to the Manitoba HIV program webinar, PEP and PrEP, what you need to know about HIV in Manitoba. My name is Kim Templeton, and I'm the program lead for the Manitoba HIV program, and I will be your moderator today. Just so folks are aware, and you may have heard the indication there that our webinar today will be recorded, and we will post it on our website after today's presentation. Today we are welcoming pharmacist Shanna Chan and Tracy Janzen Cheney to speak with you on all things PEP and PrEP in Manitoba and answer some questions that you may have. Before we begin, we want to acknowledge that the Manitoba HIV program operates on the original lands of the Anishinaabe, Cree, Oji-Cree, Assiniboine, Dakota, and Dene peoples, and the homeland of the Métis Nation. For those of you who have questions as we move through the presentation, please be sure to type them in the Q&A box. So not the chat box, the Q&A box. And we will do our best to address each of your questions in the last 15 minutes of our time together. So I'm happy to introduce our speakers today. Presenting first will be Shanna Chan. Shanna is a graduate of the University of Manitoba Faculty of Pharmacy program and completed a hospital pharmacy residency with the Winnipeg Regional Health Authority pharmacy program. She has been an HIV pharmacist with the Manitoba HIV program for over 10 years, provides the HIV and opportunistic lectures at the U of M College of Pharmacy, is an active member with the Canadian HIV and Hepatitis Pharmacists Network, and has an extended practice license in HIV with the College of Pharmacists of Manitoba. Presenting after Shanna is Tracy Janzen Cheney. Tracy graduated from the University of Saskatchewan in 2004 with a Bachelor of Science in Pharmacy with distinction and completed her hospital pharmacy residency in 2005. Before joining the Manitoba HIV program in 2016, Tracy worked on the bone marrow transplant ward, as well as in pediatrics and inpatients at the Health Sciences Center. Outside of work, she is an active member of the Canadian HIV and Viral Hepatitis Pharmacist Network, known as CHAP, and her other passions in life include figure skating and her new puppy, Dixie. Both Shanna and Tracy work at the HSC HIV clinic, which is headed by infectious diseases docs with a specialty in HIV, as well as at 9 Circles Community Health Clinic, which is a primary care clinic with a focus on HIV care provided by family physicians. And without delay, I will pass the floor over to Shanna Chan.
Thanks, Kim. I'm just going to screen share. Here we go. And one more second. Okay, there we go. I took a look at some of the people who are logged in. I'm a little bit intimidated. I do recognize a lot of friendly names though. So before we can talk about HIV prevention, I think it's a good idea to talk about where we are in the state of HIV globally, in Canada, and here in Manitoba. From this slide, you can see, and this is from 2020, that HIV is an epidemic. There's over 37 million people living with HIV, with the greatest burden being in sub-Saharan Africa, about 10 times the amount of North America and Western and Central Europe combined. What is important about this slide is that although we have effective antiretroviral treatments, it's not enough. We can see that there are 1.5 million people infected with HIV in 2020 alone. And that every day there were 4,000 new infections, both adults and children, in 2020. Again, the burden is in sub-Saharan Africa, but it is across the world. Sadly, children are amongst those that are being infected, as well as we can see that there's a change in the demographic of who is acquiring HIV. It used to be a gay man's disease, and it has evolved to being 51% women. This is a report from Canada from PHAC, and we can see that it's been pretty static for a number of new HIV infections in Canada on an annual basis, in around the range of about 1,500 people per year being newly infected with HIV. This graphic shows the differences in HIV new infections across Canada. You can see that Saskatchewan is the hardest hit at 15.7 new diagnoses per 100,000, and Manitoba follows second. So it's not good here in Manitoba what's going on with HIV. And although it says that there's been a decrease in HIV cases in 2020 compared to 2019, what it doesn't show is that it's likely because of the pandemic that people weren't actually testing. So Manitoba is not a good state with regards to new HIV diagnoses, and it could be related to drug coverage as well as how people are getting HIV. So Saskatchewan has historically been IV drug use, and in Manitoba previously it was not as much of that substance. It was more smoking crack cocaine. So again, back to Canada, we can see again, there has been a shift that we can see that the hardest or most affected group is the men who have sex with men at 60%, followed by heterosexual, acquiring through heterosexual contact, and then injection drug use. And again, we can see that there's more male than female, although females are increasing in numbers, and of those females, predominantly through heterosexual contact, as well as injection drug use. Here in Manitoba, our rates are going up. It's very, very scary. Previously, we were running around 85 to 115. Last year in 2021, you can see that the number of new HIV diagnoses went up to 168. We're 6 months into 2022, and we are on the pathway to over 200 at this point. It's growing. Compared to our neighbors to the west, we can see that Saskatchewan, their epidemic started a lot earlier than ours, again, driven by IV opioids. Here in Manitoba, our numbers are increasing at an alarming rate. Some of this being, again, the change to substance use and IV crystal meth. So let's talk about the prevention, because treatment's not enough. We also need prevention. We need a two-pronged approach. So there are many ways that we can prevent HIV. There's pre-exposure prophylaxis, there's post-exposure prophylaxis. There's also prevention of vertical transmission or mother to child, as well as a concept of treatment as prevention. We're going to focus on pre-exposure prophylaxis or PrEP, as well as post-exposure prophylaxis as PeP. So I'll be speaking about the pre-exposure prophylaxis. So I'd want to talk about the differences between PrEP and PeP. This was taken from the Katie website, which is a really excellent website. It's Canadian, so it's applicable to the Canadian landscape. So pre-exposure prophylaxis is medication taken before and after potential exposure to HIV, compared to post-exposure prophylaxis, which is taken after exposure to potential HIV. For pre-exposure prophylaxis, it's usually taken on an everyday basis, whereas post-exposure is taken every day for a defined period of time of 28 days. With pre-exposure prophylaxis, is a combination of 2 antiretroviral medications, whereas post-exposure prophylaxis is a combination of 3. And for pre-exposure prophylaxis, it's intended for regular use for an ongoing prevention of acquiring HIV, whereas post-exposure is after a single exposure. So PrEP is an effective method for HIV negative people to prevent or lower their risk of acquiring HIV when taken as prescribed. For PrEP, it's 2 antiretroviral medications taken orally once daily. And you can see that there's a star there in that that is the approved method for PrEP here in Canada. There is another method of using PrEP, but it's considered off-label. On-demand PrEP or event-driven PrEP, somewhat similar to, I guess you would say, erectile dysfunction treatment. So for what are the medications that are used for PrEP here in Canada? Well, there are 2 that are approved by Health Canada, and that is M-tricidine and tenofovir disoproxil fumarate. It can be, the trade name is Truvada, but can also be referenced as FTDF. There's also approved in Canada is M-tricidine with tenofovir alafenamide fumarate, also known as Descovy. In all practicality, it's really only the Truvada or the generic equivalent of Truvada that we're using for PrEP. We do not use Descovy for PrEP because we just can't access it. We don't have any drug coverage. There's no programs that will pay for Descovy for the purposes of PrEP, let alone treatment of HIV itself. So how does PrEP prevent HIV? Well, antiretrovirals are used for PrEP, prevents the replication of HIV. What's really important for people to know is that antiretrovirals don't directly kill HIV. Antibiotics may directly kill directly kill bacteria, but antiretrovirals work by preventing replication of the virus. For HIV to cause an infection, it needs to enter the body through infected bodily fluids, blood, semen, vaginal secretions, and then infect the CD4 cells. HIV cannot replicate it in and of itself. It needs a host, and that host is the CD4 cell. It needs to use the internal machinery in order to make copies of itself. So when PrEP is taken consistently and achieves therapeutic drug levels in blood, in the genital tract, in the vaginal and rectal tissues, it prevents HIV from replicating and causing a chronic or permanent infection. How effective is PrEP? PrEP is extremely effective if it's taken appropriately. So the use of PrEP can lower the risk of getting HIV by over 90%. So in the original study for men who have sex with men and transgender women, it didn't look as promising, and that it decreased the risk by 44%. However, when they did an analysis of those who were actually taking PrEP, so looking at dried blood spots, those who acquired HIV while on PrEP, they actually weren't taking enough PrEP or weren't taking PrEP at all. And we can see from the IPREX open label extension study that it's almost 100% for those who take at least 4 or more doses per week. So ideally you want 7 doses, so 7 out of 7. But based on the blood spot for tenofovir concentrations, they could tell that for if you took at least 4 or more doses per week, so adequate serum levels, adequate levels in genital tract, then it was protective. So we also know that PrEP is effective in the heterosexual as well in people who use drugs or IVDU. So what is the drug coverage situation here in Manitoba? Why haven't we been using PrEP? Or why hasn't there been a big uptake? It's mainly driven because of the drug coverage. It's expensive. And up until October of 2021, it was not an eligible benefit under pharmacare. It wasn't available to those who were on family services or EIA. So brand name Truvada, the original, before the generics became available, was $1,000 for a 30-day supply. The cost of PrEP has come down to a quarter of the cost, of about $250 for a 30-day supply of it. If you do the math, it works out to about $3,000 per year if you were to take daily PrEP. Now, this table shows kind of a breakdown of the cost based on what drug coverage a person may have. If you are First Nations, there is no cost. This is true. This is M-tricidine tenofovir DF. So for treatment of chronic HIV, PrEP, as well as post-exposure prophylaxis, there's no cost. effective October 2021, M-Tracy and tenofovir for the purposes of PrEP is Part 2 EDS. Prior to that, it was not an eligible benefit. So it was essentially not available to those who were relying on that type of medication coverage. For pharmacare, it is Part 2 EDS again, but again, with all medications and pharmacare, there is a deductible. So once one has paid their assigned deductible amount, then 100% of the cost thereafter will be paid by the Manitoba government. But again, there still is that deductible amount. And depending on what the income is, the deductible amount can be very, very, very high and unaffordable. So if you did the cut point of where about $3,000 is, that's equivalent to having an income of about $52,000. And again, interim federal health for refugees, there would be no cost if they're available to have this as their drug coverage, in that it mimics pharmacare and family services. So there is a Canadian guideline. Again, I would recommend people to look at Canadian guidelines. There is some differences with US, the CDC and their guidelines for the purposes of PrEP and PeP. With that, again, this was written in 2017. It was a multidisciplinary group that looked at the data, looked at the evidence, and then came up with recommendations. And with that came out the Manitoba HIV program, HIV prevention guidelines, and also the Manitoba Health came up with their eligibility criteria and clinical guidance for PrEP. So looking at PrEP, who is eligible for PrEP? We can break it down to 3 different groups. We'll talk about the first one is those who have sex with men who have sex with men, or transgender women. So those who are having condomless anal sex within the last 6 months, infectious syphilis, if they've had to use PEP more than once, if they're having an open sexual relationship with someone who has a substantial risk of HIV transmission. And we can also look at the risk of HIV infection using the HIRI MSM score, which can be found in the guidelines as well. It basically gives it a score on what the risk is. Again, so greater than 11, they would be recommended to go on to PrEP. The second group is heterosexual people. Again, PrEP is only indicated for people who are HIV negative, so who have ongoing exposure to HIV positive partners with condomless vaginal or anal sex. Again, I'll let you read through that, but basically for those who there is a potential risk for acquiring HIV. And also people who inject drugs, if there's needle sharing or equipment sharing, there's also potential for HIV infection through that route, through and contaminated equipment. So the ARCH IDU risk score is also helpful for practitioners to determine whether or not a person may be at higher risk for acquiring HIV. So you can see that score sheet there. Where is PrEP not indicated? So PrEP is not indicated for those who are in a monogamous relationship with a single partner and have no or negligible risk for having transmissible HIV. So what's considered, oops, where did that go? What is negligible or none? You can see in the box there that the person is confirmed HIV negative, that's their partner. The person who they're engaging in a relationship has a viral load less than 40 and do not have an STBBI, or if the HIV status is unknown and is not from a group that would have a higher prevalence of HIV, so the general population. So before starting PrEP, we want to do a baseline evaluation. We want to look for signs of an acute HIV because we do not want to start prophylaxis because it's insufficient to treat in someone who may have acute HIV. So signs of that include fever, sore throat, rash, photophobia, headache. We also want to confirm that the person is HIV negative before starting them on prophylaxis or preventative treatment. So we want to use a 4th generation assay, which is what we have here at CADM. We want to do that within 2 weeks of starting PrEP. We also want to screen for hepatitis A, B, and vaccinate if it's susceptible because hepatitis can also be transmitted by similar viruses that are transmitted by bloodborne diseases. We also want to screen for hepatitis C, syphilis, gonorrhea, chlamydia, STBBIs, they love HIV. They go together. So we want to identify and treat those. From a safety point of view, you'll want to do a urinalysis and make sure that their eGFR is greater than 60. Again, one of the medications in PrEP can't be used if their eGFR falls below 50. And we also want to counsel on HIV, STBBI, other prevention strategies. So we want to discuss the benefits and risks of PrEP with eligible patients. Again, daily PrEP is what is on label. So that's tenofovir disoproxil fumarate and M-Tricidabine. It's highly efficacious. We want to let people know that they are safe and side effects are rare. But the risks are, counter with that, there are risks for PrEP as well. The most importantly is if someone were to be on PrEP but they actually have active HIV, the 2 drugs being used in PrEP is insufficient for treatment. So what can happen is it can drive development of drug resistance against those 2 medications. It would make it a lot harder to treat their HIV. There are obviously side effects that are possible. Some common side effects include GI upset, nausea, vomiting, diarrhea, headache, and dizziness. Most people do tolerate tenofovir M-Tricidabine quite well, though. And we also have to look at some of the long-term side effects, including bone marrow density, which can be reversible, as well as kidney function. So if there's any more information or needing more information about PrEP or have more questions, the HIV pharmacists are also on eConsult. So it's available to primary care providers, pharmacists, anyone who has access to eConsult. So it wouldn't be a pharmacist talk if we didn't talk about pharmacology. So M-Tricidabine, tenofovir disoproxil fumarate. It takes about 7 days of taking daily PrEP to achieve maximal concentrations in rectal tissue and about 20 days for vaginal tissues and in the blood. So we would counsel people to not have condomless sex, or they would not be maximally protected until 7 days if it was anal sex, or if it was vaginal sex at 20 days there. We also know that we need to monitor for people's kidney function, and before initiating M-Tricidabine tenofovir, we want to ensure their GFR is greater than 60. We'll want to dosage adjust if their creatinine clearance falls below 50, and we may not want to continue using this particular medication as well, as there's potential for toxicity to the renal tubules, but is potentially reversible on discontinuation, but not necessarily guaranteed. We know that tenofovir disoproxil fumarate can also decrease bone mineral density, but it can rebound after discontinuation. So overall, for M-Tricidabine tenofovir, we do have to be aware of potential side effects, including rash, abdominal pain, diarrhea, dizziness, headache, myalgias. So who can prescribe PrEP? So healthcare providers who have prescriptive authority by their licensing body can prescribe PrEP. Ideally, it's being for those who are providing primary care, so that's physicians, nurse practitioners, and potentially in STI nurses as well. Pharmacists, we cannot independently prescribe PrEP. Pharmacists can prescribe medications, but usually in a collaborative practice. But if you were in a collaborative practice in a primary care setting, that could be a possibility. So for someone to be able to prescribe PrEP and have it eligible under pharmacare, under EIA, or Interfederal Health, the prescriber would need to register with Manitoba Health to become a PrEP prescriber. And there's the link to the website where you can do that. You can also Google HIV Manitoba, and it'll bring you to the government website. And there's under the forms, you can find that form as well. To note, people who want to become a PrEP prescriber, once you submit your application, you're not going to get a response that you've been approved. It's assumed that you send it in, that they've received it, and then you can go ahead and prescribe if it's appropriate. This is a sample of what the application looks like, and you're basically declaring that you have read through the guidelines, you've read through the eligibility criteria, and that you will follow through with those criteria. Where can you get PrEP? Well, all pharmacies can dispense PrEP. M-Tricidabine tenofovir, again, we use this medication not only for the treatment of HIV, but it can also be used for the prevention of HIV in both PrEP and PeP. With that being said, pharmacy staff will not be able to verify if a prescriber has applied to be a PrEP prescriber. That information is only housed with Manitoba Health, and it's not like methadone or Suboxone where you can look it up. There's no list to look up, so you can't verify. What I'd like pharmacists to know is for this medication, because it can be used for a variety of different reasons, I think it's really important for you to know why it's being used for that particular person to ensure that it's appropriate. So in the treatment of chronic HIV, we're usually using 3 drugs. So we can't just use M-tricycline, tenofovir, DF. In PrEP, yes, that is appropriate dose. That is complete. That is enough medication. And in PeP, again, it's not enough. It is 3 drugs. So needing to know why we're using M-tricycline, tenofovir, and to also for you to know is that this medication also has hepatitis B activity, so it can be used for the treatment of chronic hepatitis B. So where do you find HIV service providers? Where do we find these people who prescribe PrEP? There's actually on the Manitoba HIV.ca website a services map. There's not that many people who are registered, but it actually can help locate people who are interested in PrEP with a PrEP prescriber. So we do have PrEP prescribing through our STI nurses and Nine Circles Community Health Clinic, our other HIV site. Baseline evaluation. So again, with PrEP, there needs to be some baseline testing. Obviously, there needs to be testing at the 30-day mark, making sure people are tolerating it, and every 3 months. It's very important that when prescribing PrEP, that you're only prescribing 3 months worth at a time, because we want to catch anyone. We want to retest for HIV and make sure that a person's not continuing to take M-tricycline, tenofovir if they have actually developed HIV. So PrEP should be discontinued if someone tests positive for HIV, if they've seroconverted, because we don't want to drive drug resistance. PrEP is not meant to be lifelong. It's meant to be used during the time in which they may be at higher risk for acquiring HIV. There are guidelines on how long you need to continue PrEP after that period of time where you're no longer at higher risk. We also need to assess whether or not PrEP is also the medication is also being co-used for the treatment of chronic hepatitis B, because if we stop it, they may have a hepatitis B flare. And again, if someone wants to resume PrEP, they would have to start the assessment process all over baseline again as well. So how can non-prescribers help with HIV prevention? This is the first step, is learning about what HIV prevention strategies are available. You can help by identifying those who are at higher risk for HIV and helping provide resources and information on how to find a PrEP provider to assess for eligibility to help with adherence support. So we know that it works. It works really, really well, but it doesn't work if you're not going to get an adequate serum levels. It's not going to work if people aren't taking the medication. It's not going to protect them, as well as helping navigate with the drug coverage of PrEP and knowing that it is now an eligible benefit under pharmacare, family services, and EIA. But again, keeping in mind that there still is a deductible amount for those who are just on pharmacare. There are some private insurance that will help pay towards the cost of medication. So for example, Blue Cross, as long as it's covered under pharmacare, then it would be ineligible under Blue Cross as well. And that is my section. So I'm going to hand it off to my colleague, Tracy.
So for post-exposure prophylaxis, it's the provision of 28 days of combination antiretroviral medications to prevent the infection of HIV within 72 hours of a single exposure. The antiretroviral medication works by blocking the viral replication. So after exposure, HIV initially causes local viral replication in tissue macrophages or dendritic cells. If the HIV virus is not contained, it is followed within 42 to 72 hours by replication of HIV in regional lymph nodes. Viremia then occurs within 72 to 120 hours of virus exposure. So start of PrEP is time sensitive. So how do we decide to start PrEP? It's based upon two factors. The first is if the source has a high likelihood of having transmissible HIV, and if the exposure type is moderate to high risk. So the strongest predictor of HIV transmission from the source to the exposed is the viral load. So the viral load is particularly high in patients who are acutely infected with HIV in which it spikes, or in patients with a high viral load. In patients who are on antiretroviral medications and their viral load is undetectable, they are untransmittable. So in that situation, we would not start PEP. In terms of you assessing the risk for if a person would likely have HIV transmissible, we also look to see if the probability of having HIV is higher. So examples of that would be people with MSM in endemic area or IVDEU. The CMAJ guidelines also suggest that PEP could be potentially started in patients who are virally suppressed but have a co-commitment STBBI. So an STBBI breaks the mucosal or the genital barriers, increasing transmission, and there's also known to be higher viral shedding in that scenario. So the type of exposure is also considered in assessing whether PEP should be started. So in patients in which PEP is indicated, it would be with high or moderate risk. So the highest is obviously a blood transfusion. Next would be anal receptive sex with an estimated risk per act at 1.38%, needle sharing at 0.63%, and per continuous injury, which would be at 0.3%. So moderate risk would be anal insertive, vaginal receptive, vaginal insertive, or mucous membrane. So in the scenario where there's low or negligible risk, even if the patient is known to be HIV positive and higher viral load, in that situation, PEP would not be started. So basically, those include scenarios like kissing, spitting, or oral contact in the absence of mucosal damage, mouth-to-mouth resuscitation, human bites not involving blood, discarded needles outside of the healthcare setting, exposure to saliva, urine, vomit, feces, nasal secretions, sputum, sweat, or tears. The most common scenarios that I encounter at 9 Circles in which patients present initially to the ER for non-occupational PEP would include sexual assaults and needle sticks injuries. May want to also consider the risk of HIV transmission and sexual assaults may be higher due to the presence of genital rectal trauma. And also I was trying to look whether the population may be potentially at higher risk. I could only find one study in which they examined convicted sexual offenders at Rhode Island and found that 1% of men convicted versus the male population of 0.3% had HIV. And then for needle sticks outside of the healthcare facility, and if the needle has not been recently used, the risk of HIV transmission is negligible. The HIV virus, when it's outside the body and it is drying, the viral concentration substantially decreases within a few hours. So how do people access PEP in Manitoba. So for the initial assessment of PEP and the baseline workup, they are seen in the emergency department or urgent care. If they are a sexual assault victim, they can be seen at HSC, and they're seen by the STAIN nurse, which is a specialized nurse trained to manage sexual assaults encounters. Once they've completed their workup in the emergency department, they send a referral to the community sites for the follow-up blood work. So there are 5 community sites, 9 circles: Access Fort Garry, Access Winnipeg West, McGregor, and Norwest Co-op Community Health. Follow up at the community PEP sites could also be for occupational exposures for fee-for-service or self-employed healthcare professionals. In terms of adolescents, they can be seen at the Child Protection Center, at the Health Science Center. Usually those people are who they see are based upon what their physical maturation is and if they're prepubescent. In terms of occupational exposure, if you're an employee of the WRHA, shared health, city employee or firefighters or paramedics, you're followed up by OSH. So Manitoba, what is new in terms of PEP, they have moved from dual therapy to triple therapy. So there are many different PEP regimens that can be used. Usually they consist of 2 nucleoside reverse transcriptase inhibitor with a 3rd agent, which is an integrase inhibitor or protease inhibitor. In Manitoba, what has adults and adolescents aged greater than or equal to 13 years of age without renal dysfunction is raltegravir in combination with M-tricytidine and tenofovir. And for kit B, that's used in patients who have kidney damage with mild renal dysfunction. So basically you can use the combination tablet of zidovudine and lamivudine up to, so if the creatinine clearance is greater than 50 mils per minute. Unfortunately, Manitoba Health used the combination tablet instead of the individual components, which would allow greater flexibility in the dosing, because zidovudine doesn't need to be dose adjusted until the creatinine clearance is 15. And technically in the monograph, it says lamivudine needs to be dose adjusted at 50, but in the Manitoba HIV program and across Canada, they typically would use lamivudine at a regular dosage down to a lower creatinine clearance of 30. So in the emergency department, they do receive a 3-day starter kit, and then they receive the prescription to continue to be filled in a community site afterwards. I just wanted to show, I wanted to limit my discussion to adults mostly, but just to let you know, there is a pediatric PEP kit as well. And they've chosen to use lopinavir and ritonavir in combination with lamivudine and zidovudine for the PEP kit for normal renal function. And on the right-hand side, that's what like the prescription that you'll see from Shared Health or WRHA. So what kind of workup that we need to complete? It's much the same as PrEP. So we want a negative HIV test before we want to confirm it. If they were HIV positive and they had an infection, we may want to use a different regimen, or we also wanted to make sure it's safe to start if they have a low CD4 count. We repeat the HIV testing at week 4 and week 12. Since there's other bloodborne illnesses, we also test for hepatitis B, hepatitis A, and hepatitis C. So if they're non-immune, we do vaccinate, and if they're high risk, they may receive the vaccination plus the immunoglobulin against hepatitis B. It's also important to figure out if they're hepatitis B positive, because tenofovir, M-tricytidine, and lamivudine, all those medications can be used to treat hepatitis B. And once we stop the treatment of PEP after 28 days, there's a potential for hepatitis B to flare up. In terms of the hepatitis C, if you were at higher risk, or if the source was positive, we would test for the RNA at 4 weeks and the antibody at 12 weeks. If you were low risk, you would test at 6 months. And then for our patients in which it was a sexual exposure or it was a sexual assault, they do routine doing STBBI testing at baseline, and as well they receive empiric treatment for chlamydia and gonorrhea. And also, just to highlight, patients who were victims of sexual assault are also eligible for the HPV vaccine. So the bright spot in Manitoba is that we have near universal coverage of PEP. So if you have an active Manitoba health card and you're not covered by another program such as NIHB or EIA or for refugees, then you're eligible to have Manitoba HIV medication program cover the cost of the medication. And that is irregardless of what your deductible is or what your income is. So the government covers 100% of the cost of the medications. If you were to pay out of pocket for the combination of raltegravir, emtricitabine, and tenofovir, that would be approximately $1,000 a month. And then just to put this in a bit of perspective, the treatment of HIV for lifelong would be about $12,000 to $15,000 per year for the rest of your life. So it's cost effective to prevent HIV. In terms of other programs that provide coverage, the Workers' Compensation Board covers for 100% for occupational exposure. So you need a doctor's report, plus you need to phone that phone number to initiate a claim. And then in terms of what existed before the Manitoba HIV program, which still can be utilized, is for sexual assault victims, they can receive compensation under the special victims compensation. The caveat to this is the victim has to file a police report or anonymous report through third party in order to qualify for this assistance. However, if they do go down the route for special victims, they also have access to counseling as well. So these are what the forms look like. So on the left side is the Manitoba HIV program, and this is for coverage of PEP. So at the top, you need to indicate no, client meets eligibility for the Manitoba HIV program. You have the option of just filling out this form and then filling in a prescription separately. So some of the downfalls that we've seen with this form is that it's not as clearly outlined which medications can be given for PEP. And sometimes what happens is prescribers have filled out either just one medication, or sometimes they filled out two or more medications. So we're hoping to advocate so that we can streamline the form in the future. In terms of, so PEP is 100% covered for post-exposure prophylaxis. There's also a program by the Manitoba HIV program for coverage of HIV medications for short-term for patients who are applying for pharmacare or are trying to get on the deductible installment payment program. So it's meant as a bridging program, and they get 3 months of medication, 1 month at a time, covered 100% by the government. So that form also looks somewhat similar to this one. Unfortunately for our community pharmacists, the process isn't as easy. It's a little bit cumbersome. So what the physician needs to provide is the prescription plus the form. Once the pharmacist receives the prescription, they need to contact the DPN help desk to confirm if the patient has active Manitoba health coverage. During the instructions indicate that the pharmacy needs to ask the DPN help desk whether it's going to be filled as a drug utilization or a fiscal adjudication. So what Manitoba Health has indicated to us that they're only doing it under drug utilization. They're not using fiscal adjudication to go towards the pharmacare deductible. And that is also similar with the Manitoba HIV program for the treatment of HIV. Then in order to receive reimbursement for the cost of the medications, depend reversal adjustment form is need to be filled out. You need to indicate on it that it meets the HIV medication program eligibility. And you also need to attach the form and the prescription to it and fax it to Manitoba Health. So there's lots of potential for this. It's hard to keep track of patients who are on this program, and it's time consuming for, I assume, time consuming for billing. So HIV infections share similar routes of exposure. So there's also hepatitis B. So hepatitis B is highly infectious that can be transmitted in the absence of visible blood and remains on environmental surfaces for at least 7 days. So it's transmitted through percutaneous, mucosal, or non-intact skin exposure with infectious bodily fluids. So it has much higher risk of transmission than HIV. So the highest risk of transmission would be in the group of like surface antigen positive and hepatitis B, E, H antigen positive. So in terms of prophylaxis in patients who don't have protective immunity or non-responders, who are unvaccinated in high risk exposures, the hepatitis B immune globulin may be given with the hepatitis B vaccine. So best if given within 48 hours, but up to 7 days for percutaneous and up to 14 days for post-exposure for sexual assaults. The specific recommendations of when to use this is in the post-exposure prophylaxis for HIV, Hep B, and hepatitis C protocol. With hepatitis C, for percutaneous, some of the newer studies have reported low risk like HIV 0.2, and some report up to 1.8%, which would be higher than HIV. However, Hep C is not transmitted that well through sexual exposure or household contact, except for there is a higher risk for receptive anal sex. So potential side effects of HIV, PeP. So the combination of raltegravir, M.Sc, and tenofovir is generally well tolerated. Common side effects is insomnia, headache, nausea, loss of appetite, and diarrhea. From experience, most people feel the worst a couple days when starting the medications, and then those potential side effects can dissipate. One thing to note with raltegravir, it can rarely cause like a rhabdomyolysis or myalgia with it, and extremely rare any kind of mood changes with it. In terms of the lamivudine and zidovudine, it's poorly tolerated in most patients. So the biggest part is GI upset and feeling fatigue or malaise. We do need to check the CBC at week 2 to rule out any kind of anemia and neutropenia with the combination of lamivudine and zidovudine. So fortunately, with the move to raltegravir in combination of tenofovir, M.Sc, there are not very many drug interactions. I will note for the pediatric, the lopinavir-ritonavir, there's major drug interactions. It's a potent inhibitor of CYP3A4 and an inducer of many enzymes. So fortunately, probably peds aren't on a lot of medications. To highlight with raltegravir, it does bind to divalent cations and forms a complex at the level of the gastrointestinal tract, which prevents raltegravir from being absorbed. So administration of raltegravir 4 hours before or after divalent cations. You could administer, because in the twice daily raltegravir with calcium antacids, and generally aluminum magnesium antacids aren't recommended. In terms of another potential drug interactions, strong hepatic inducers and with raltegravir, such as rifampin, may reduce the levels. Ways to screen for HIV drug interactions. There are 2 sites that are really good that can be downloaded on the internet. They also have free apps available. So important to discuss with patients the benefit and effectiveness of the medications. There's no RCT trials to talk about benefit of PEP when they've looked at occupational exposures. It has reduced the risk of HIV transmission by 80% when they've looked at a meta-analysis of cohort of studies. In 2,000 patients, only 1 seroconverted due to PEP failure. So it's important that the patients get the full course of treatment to prevent HIV. So what do you do if a dose is missed? If you forget it, you take it as soon as you remember. For M-triscytidine tenofovir, since it's once daily, we say up to 6 hours before the next dose is due, you could probably take it and then go back to your normal dosage. With raltegravir, in some people who are kind of on of it, you could potentially double a dose just because of raltegravir also exists as a once daily product that's 1,200 milligrams once daily. So you could double and then go back to your normal dosage. So it's important if patients develop signs and symptoms of seroconversion to seek medical attention. So that's like a flu-like illness. So it's headache, rash, sore throat, myalgia, arthralgia, fever, chills, any kind of thrush that they seek medical attention, and then we can do an HIV test. Another thing to point out to patients is that they need to take precautions to prevent HIV and hepatitis transmission to others. So there's the list below indicating things that they need to follow. So final thoughts. PEP exposure is an emergency. It's time sensitive. Ideally, it should be started within 2 to 4 hours, but no later than 72 hours. You can give the first dose of medication before you get your lab results back. PEP should be part of a combination prevention strategy that includes behavioral interventions or structural changes such as safe injection supplies and other biomedical interventions such as opioid replacement therapy. So last but exciting, the new Manitoba HIV program for PEP does improve accessibility by removing cost barriers. So that's exciting. There's an opportunity for pharmacists and physicians to discuss transitioning PEP patients to PrEP if they're at higher risk. Compared to the old medications, raltegravir, M-triscytidine tenofovir is very well tolerated. In terms of things at the pharmacy, it's an all or nothing approach. So patients should leave the pharmacy with both medications to prevent the risk of dual or monotherapy, and in which they would be at risk of failure, PEP failure, or potential development of resistance. Pharmacists are also positioned to address adherent issues like tolerance, so to prevent premature discontinuations. And it's also really important to make sure the supply of antiretrovirals is not interrupted between the starter kit from the emergency department and filling of the prescription in the community. And we're really willing to work with you if you're having trouble getting in both medications. There are other pharmacies that dispense PEP more often. There's also the potential in some circumstances for the patient to get another starter kit until the medication can be ordered in. Okay, any questions?
Thanks very much, Tracy and Shanna. That was great. We've got a few minutes for some questions. And just as a reminder, if you do have questions, to please put them in the Q&A box, not the chat box. So we'll start with a question from Kelly here. What are the criteria to meet Part 2 EDS or Truvada? I believe this is probably a question for Shanna.
Yes, I'll take that question. Good question. So I'm just going to share my screen again. And where is it? Here it is. Here we go. So this is bulletin 114, and you can, it's hard to see because it's pretty small. I'll just make it a bit bigger. So you can see that there are a variety of different generic versions of Truvada or M-Tricity and tenofovir. So the criteria for part 2 follows exactly what's in the eligibility document by Manitoba Health. So inclusion, again, it's broken down by risk: men who have sex with men versus heterosexual versus people who inject drugs. So I basically took my slides from here. It matches exactly. So if they meet inclusion criteria, then they meet part 2 EDS. And for those folks who are on who don't know what part 2 EDS means, it means that either the pharmacist or the prescriber can verify that they meet the criteria. It's not, you don't need prior approval. You don't need to contact Manitoba Health in order to get approval for that particular person. It can be either the physician, or sorry, the prescriber or the pharmacist at the community level who can indicate that the patient meets part 2 EDS for it to be eligible under pharmacare or family services. Hope that answers your questions, Kelly.
Great, thanks. Moving on to Riley has a question about how long after HIV exposure can we expect symptoms of acute HIV infection to manifest?
Yeah, so that's another great question. So it varies. So it can be within a few days of being exposed to HIV up to about 2 weeks. So between, I'd say, around 5 to 14 days is when people may experience symptoms of acute HIV, but keeping in mind that some people don't experience any symptoms of acute HIV. But we do always ask when trying to determine whether or not if someone has acquired HIV, try to look at the timeline on when they might have been exposed to the virus.
Thank you. On to David has a question about if there are no signs and symptoms of acute HIV infection, or are no signs and symptoms of acute HIV infection not a requirement for PrEP under the Canadian guidelines? And can a patient acquire coverage for FTAF if they experience renal decline or bone mineral density issues on FTDF? I believe this one's for Shanna as well.
Yeah, just kind of looking at it again. So I guess you could make a case to try to get FTAF over FTDF if there's a decline in renal function or bone mineral density. The bone mineral density thing is going to be an issue because you can't you essentially can't get a DEXA scan for a year, and we don't do baseline bone mineral densities. Maybe at someone who is at higher risk or is already diagnosed with osteoporosis. That's a potential that they could try to apply to Manitoba Health pharmacare as an exception, but I don't know if they would approve it or not. And yes, you have to be assured that they do not have acute HIV. You do have to make that assessment and ask the questions whether or not they have any of these symptoms. If not, you might want to wait another 2 weeks before putting them on PrEP.
Okay.
That answers your question.
Thank you.
And I
And
think
a
a similar question from Michael.
Yeah. Another question for Michael. Is there coverage of TAF FTC for PrEP for patients with lower CLCR than the TDF FTC monograph allows? What options are available for PrEP for patients with CLCR less than 30?
So in Canada, the only option, the only approved medications for the use of PrEP is tenofovir, diazoxyl fumarate, or tenofovir alafenamide plus M-Tricity. In the US, they have injection cabotegravir. That's been approved by the FDA. That's not something that's available here in Canada. Has not been approved by Health Canada, and we're not a big enough market to even have that product available, even for the treatment of HIV. So really, there aren't any options for PrEP for someone who has a compromised renal function of creatinine clearance less than 30. And there really isn't any guidance in the product monograph to dosage adjust tenofovir, diazoxide fumarate, M-tricidabine in someone who has a creatinine clearance less than 50. I mean, theoretically, in treatment of HIV, they say that you can decrease the dose to every other day dosing, but it's not clear for the purposes of PrEP on dosage adjusting.
Great. There were a couple of other questions that came in advance and in the chat. Are we seeing any resistance developing to these medications? For Tracy or Shanna?
For PrEP, we don't have a lot of people who, at least I don't think we have a huge amount of people who are on PrEP in Manitoba. Again, my background is treatment of HIV, so my patient population already has HIV, as opposed to the general primary care population. There is always that risk of acquiring HIV if someone is not taking the tenofovir, diazoxide fumarate, M-tricidabine on a enough basis, or at least 4 doses per week, in order to protect them if they were to be exposed to HIV. There is always that risk. And that there was another question I saw in, I think, the chat, where how often do you need to test for HIV in the setting of PrEP? And you do have to test at baseline. You need to test at 30 days as well as every 3 months thereafter. The rationale behind every 3 months is that if someone were to be exposed to HIV and actually acquire HIV, you would be able to, you would identify it on the antibody test. Most people, if they were to develop chronic HIV, would show a positive antibody by 3 months. They would seroconvert.
Great. Okay, thank you so much, Tracy and Shanna. That was really wonderful. I hope everybody found it valuable to your practice. You will be receiving a survey to evaluate the presentation today, so please take a moment to let us know how we did. Also, please note that we are building an inventory of healthcare provider resources on our website, including those that are related to PrEP and much of what was covered in today's presentation. If you plan on becoming a PrEP prescriber and are willing to receive patient referrals for PrEP, we encourage you to add your services to our new HIV services map, which I believe Shanna shared earlier in the presentation. You can easily register your services through a form on our website. You'll be able to find a recording of today's webinar on our website as well. And for any questions about anything that was discussed today, please feel free to be in contact with me at the email address below, and I will connect you to the appropriate people and resources. So thank you very much for your attendance tonight, and have a wonderful week.